You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Before we get started, I just want to say how much I appreciate your listening and your support. It really means a lot to me, and it helps me to stay on course and to keep trying to share the best of pediatric emergency medicine with you. To celebrate the Playbook's turning the big 3 years old, I thought I'd stir things up. Today will be the first in a series about clinical reasoning, how we make our decisions. You know, sometimes I think we get so caught up in chasing after the answer that we can lose sight of two things. First, there may be multiple ways to get to that answer. And second, there may not be any one solitary answer. I'm sure we can all think of ways that we've been tricked by an atypical presentation, or maybe the order in which the information is known to us. It can skew us depending on what we see first, or even just whatever is going on within ourselves on that particular day. So we make our own personal clinical rules. Maybe it's one that everybody shares. A teenage girl or a woman who has belly pain, she needs a pregnancy test. Or the patient who seems a little altered, he needs his blood sugar checked. Those are the easy ones, but we all through experience have built up a set of things that we always do in certain circumstances. Why? It's to catch ourselves when we're distracted, or if the presentation ends up being atypical for something that is typical. It's our own personal safety net. To quote an awesome emergency physician, we run through minefields with clown shoes on. Our job is tricky, even when we're especially on our game. What I just mentioned are just concrete, pragmatic examples of how we do our best to stay in one piece. Well, specific, concrete, personal rules will only get us so far, and we need to build up our experience just to get there. They're great, but they work best for things we can recognize correctly right away. To develop ourselves further as clinicians, we need to do a little bit more. We need to think about how we think. We need a safety system, not just safety examples. So today, we'll delve into a clinical reasoning framework, deductive reasoning, where the conclusion is supposed to be guaranteed. Or is it? In the next two segments, we'll contrast that with inductive reasoning, where the conclusion is merely likely. And finally, we'll bring it all together with abductive reasoning, where we just take our best shot. Let's start with deductive reasoning, because it's the most basic and mechanical of the three types of clinical reasoning that we use, and it's a good reference for the other two. Deductive reasoning is Sherlock Holmes. It's taking points of data and making a guaranteed conclusion. Before you say, wait a minute, we almost never can do that in emergency medicine. Well, sure we can. Someone falls, he has pain and tenderness and a cortical disruption on X-ray. Well, that, my dear Watson, is a fracture. Sure, you could come up with an alternative conspiracy theory, but give me a break. Now, that's a very simplistic example, and we almost don't need any reasoning when we see that presentation. We need reasoning when we have to guide our brains actively, when we need a pause and some structure in our thinking. Deductive reasoning is all about an ironclad conclusion. We start out with a hypothesis. We look at the possibilities, and we reach a specific logical conclusion. In deductive reasoning, we go from the general, the hypothesis statement, to the specific, what we observe. Based on this combination, we arrive at a conclusion. Okay, let's try this on for size. For deductive reasoning, we need a general statement. How about this one? Red currant jelly stool is pathognomonic for intussusception. Okay, good to know. Thank you, textbook. You go about your day. You see a few kids, and lo and behold, Johnny shows up. He's 2. His mother brings in his diaper that has red currant jelly stool. So we go from the general, red currant jelly stool, to the specific observation, Johnny's diaper. Deductive reasoning will say, since red currant jelly stool means intussusception, general statement, and Johnny has red currant jelly stool, observation, then by deduction, Johnny has intussusception, definitive conclusion. Nailed it, right? No? Let's think about this for a moment. Deductive reasoning can be powerful and simple, but it's a machine. It's black and white. Data in, data out. In addition, deductive reasoning requires that each premise be true, completely and totally. That's how the machine works. It's both its strength and its weakness of deductive reasoning. Simple, powerful, but vulnerable. Can we poke holes in this line of reasoning? Well, let's look at the premises. Premise 1, red currant jelly stool equals intussusception. Does it? We know that it can be a late finding in intussusception, but does it always mean intussusception? Well, what is it? It's just a mix of sloughed mucosa of blood and of stool. In the case of intussusception, focal ischemia to the mucosa causes, well, just what we see in the diaper. But can you think of other reasons that this might happen? Other causes of bowel ischemia? Or even other causes of irritation causing blood and mucus? Also, bloody mucus is in the eye of the beholder. There may be some inter-rater reliability variation with this. As an aside, when we get excited about a diagnosis, we want to find it, don't we? Anyway, someone can have what we call red currant jelly stool and not have intussusception. Intussusception can also exist with or without red currant jelly stool. So you see here, premise 1 is already in question. Let's move on to premise 2. Johnny has red currant jelly stool. Is it? Did he just eat multiple helpings of beets? Or drink a whole lot of Kool-Aid? Or maybe it's just plain old mucus and blood. So you can see that what could have been an easy, rock-solid case of intussusception, it's turned into a question of intussusception. Not so ironclad now, is it? With any method of clinical reasoning, if you put garbage in, you get garbage out. Deductive reasoning is simple and powerful, but it's the most vulnerable to questionable data. This is why it's important to know sensitivities and specificities of each exam that you do, or even positive predictive value and negative predictive value. Deductive reasoning can be great. It's a great machine. Like a calculator, if you key in all of the right numbers, then you get a solid answer. If you have lots of, say, rounding, well, then you get off the mark. Johnny's case can be strengthened. How? Well, we need to know more. This is why ordering tests on people you haven't seen based on the chief complaint can get you into more trouble than you think you're solving by being efficient. Let's go talk to Johnny and his mother and use that powerful brain, that powerful calculator between our ears. So, Johnny is 2. It's 11 p.m. He's been cranky for the past 3 or 4 hours, and he's refusing to sleep. He's an otherwise healthy boy. He vomited once today, but no diarrhea, no fever, nothing else. I know what you're thinking. Oh boy, this could be anything. So, let's get more context. You dig a little deeper, and then some more. What was going on today? It turns out, yesterday was his cousin Rob's birthday, and all the kids were eating junk food, spicy hot Cheetos, red-colored birthday cake, and jumping up and down on the trampoline, basically our worst nightmare of a toddler party. So, now what? Let's make a differential diagnosis based on what we know. Could it be gastritis from the flaming hot Cheetos? Could it be food coloring from undigested frosting? Could his vague symptoms be from pain from musculoskeletal injury, brought to you by the toddler fracture generator? Intussusception, because, well, red currant jelly stool. Or just vague symptoms from being amped up on sugar and cousins. Okay, good differential. All of these general statements are based on hypotheses. Let's take each of them and temper them with our specific observations. General statement. Flaming hot Cheetos cause gastritis. This may be gastritis, but his belly is soft and he's tolerating fluids by mouth and he doesn't seem very symptomatic now. This one may drop lower on the differential. The general statement was true, but the specific observation didn't match. General statement. Food coloring can cause bloody-looking stools. Let's check if this specific observation matches. Uh-oh, guaiac positive. No match here. Okay, going down our list, musculoskeletal. General statement. Sprains, strains, and fractures can cause fussiness. Yes, this must be it. Trampoline plus fussy toddler, but his total body check is normal. Okay, let's try to deduce further. Intussusception. Well, we may have no other reason to explain his symptoms, so maybe we look into it. And finally, the differential diagnosis does include vague symptoms not otherwise specified. Yes, that may be true. There's no test to prove the cause of his crankiness, and yes, sugar plus excitement plus running around chasing cousins can cause an overtired, strung-out, cranky toddler, but we're allowed to miss this non-diagnosis. So, you see, deductive reasoning relies on the general statements you apply and the observations you see. But the trick is, you have to invoke the appropriate general statements, those that reasonably apply. And you have to recognize the observations accurately. This kid's differential diagnosis is still open, and you may just have to go digging for more historical clues or physical exam findings. It would be nice if we could blindly apply an algorithm to every patient, but that's just not a sustainable practice of medicine. Again, not to malign deductive reasoning, there are times when we need it. I am sure you can think of the many occasions where you've exhausted many studies in the ED and you still know that something must be wrong with your patient. He's still sick and I can't explain why. This is where a methodical, iterative, step-by-step approach will help us. These concerning patients are admitted. Lots of tests and re-examinations and consultations are done, and maybe 2 to 3 days later, maybe 2 to 3 weeks later, all of the options are addressed and methodically pursued. The general statement is, this patient is sick. Theories are generated. That is, the differential diagnosis is created and observations are made and gathered, More and more data is generated through tests or through time, and the large list becomes smaller and smaller until it contains one or two working diagnoses and hopefully finally just one, deducing from the general to the specific. Now, we can't do that with every patient. Let's take the example of a syncopal event. You could do a lot of tests, a lot of things, gather more data points, and do an extensive workup. Deductive reasoning needs and feeds off of data points. But you may also just use your best judgment and decide that the 3-year-old who was previously fine, who got his ice cream stolen away by his older brother, who cried and turned blue and fainted and then was totally fine, it's probably, well, just fine. You may or may not get an EKG for the first time this happens. Likely it's all going to be just a breath-holding spell. The same general statement, syncope in children is often benign, may or may not be the appropriate general statement for any particular case. For example, take the 13-year-old boy who collapsed and was unresponsive after running in a basketball game. In other words, general statements or hypotheses, aka the infinite number of differential diagnoses, are often true regardless of the setting. Some statements, they're more reliable than others. However, we have to apply these general statements to the appropriate patient. The observation that we see in front of us also must be valid. Now, it gets interesting. We are at an intersection. Which technique should we use? Deduction, induction, or abduction? Deduction would make you admit every child, regardless of what you thought, to feed the data monster. Sure, the 3-year-old may have breath-holding spells, but deduction would compel you to rule out hypokalemic periodic paralysis, genetic syndromes, methemoglobinemia from drinking well water, and we could go on. Inductive reasoning, in contradistinction, takes specific findings and works backwards to a general theory. He syncopized. I need to think about certain diagnoses that I'm responsible for when I use inductive reasoning. So, I'm responsible for PE, for cardiac dysrhythmias, for trauma, ingestion, and so forth. That is what we often do in the ED. For high-risk complaints, there are certain diagnoses that we own. Regardless of how likely they are, regardless of what the deductive process would say, we have to rule them out. So in our case of the question of intussusception, our deductive reasoning would get us closer to a specific proven conclusion of a diagnosis, probably over time. The inductive side of our brain would say, hey, we have to prove it's not intussusception. We take a certain finding, red currant jelly stool, and that is enough to look into our general hypothesis, intussusception, regardless of how likely or unlikely it is. The trigger is that the stakes are high to miss it. We tend to use deductive reasoning, going from general theory to specific diagnosis, on our more stable but maybe concerning patients. We start with our huge list of what could be causing the presentation and we whittle it down. In other words, we use deductive reasoning for those cases when we have the time and the resources to figure it out. This is often started in the ED and followed up with an in-house investigation or maybe during outpatient management. We're probably in this mode in the ED about 10% of the time. Now, I just made up that number, but you understand I'm trying to illustrate a point. Now, we tend to use inductive reasoning for high-risk presentations. We go from high-risk concerning feature and we assess for a dangerous global reasoning, regardless of how likely or unlikely it is, because it's a high-risk feature. We don't use inductive reasoning for every patient that comes in. So we have to be careful here because not every cough needs $1 million workup, but a cough with hemoptysis, syncope, and a blood clotting disorder surely does. We're using this mode, inductive reasoning, probably about 20% of the time. Again, this is just a coach-generated number. Finally, we have abductive reasoning, where we have an incomplete set of observations, and some things are just not knowable here and now. Abductive reasoning goes off our best guess. It's a great way to generate hypotheses that need to be tested further. Sometimes that test could just be the test of time. Sometimes that's a specific course of action. In the next 2 installments, we'll dive deeper into inductive reasoning, and we'll contrast that with what we've discussed so far about deductive reasoning. Then, in the last of the 3-part series, we'll bring it all together by reintroducing the troublemaker abductive reasoning and seeing how they might all be able to play together nicely in the sandbox. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.